Thank you, Davis, for those words that go before all others, and for starting our meeting off in a good way. I just want to give a little bit of context before we get into the real detail of the presentation. And I think part of it is to go back really to the origins of the discussion about First Nation Health Authority and creating this authority within the province, and really looking at the opportunities that really arise because of that creation. Of course, this is really historic, and it's been an important opportunity to work with all First Nations. And I think in that spirit as well is really why we're hosting these meetings and wanting to make sure that, you know, all of the information is readily accessible. Part of the work, even before a lot of the details was developed, was that this PharmaCare approach, which is administered through the province via a contracting arrangement, this was really explored as one of the options way before the organization was created, because it was recognized that there were really unique opportunities and really important ways to look at delivering services differently. So this really has been in exploration for, I would say, 10 years. Part of the then recent activities is that this is also a public service. And that part of this process then permits us to engage with this public service as really a way of not going to public tender. So we are allowed to do this sort of arrangement because of the style of service that it represents. So that's really an important part of the context. And it really permits us to move ahead in a way that's still shaped by the First Nations Health Authority to deliver this important service. So of the programs provided by what was called federally the First Nations Non-Insured Health Benefits Program, and which we of course refer to as the First Nations Health Benefit Program within the province, the pharmacy program is really the largest and most complex of those services. So in terms of moving ahead then, this is an important aspect to transformation of services. So I also want to point out that now, right after this, we're moving quite quickly to transform the dental services, medical supplies and equipment, as well as mental health services that are also part of our transfer to FNHA. So there are, so this is the first part, but I think it's really important part. And then looking at how we move to these other areas will be extremely important. And as also, as we know from our trips across the province, that these are very important and of considerable interest to First Nations as well. So there's a lot of benefits to us joining PharmaCare, and some of those will come over and become more apparent and are part of our exploration and discussion today. And I just want to, with that context, just say that now going to Darren McKnight, who's the Director of Benefit Management and the First Nations Health Benefit Team, to highlight these key elements.
Thank you very much, Richard. In addition to my role in benefits management, I'm also the business lead on our PharmaCare transition project, and I'm really pleased to be able to have the opportunity to come here to share what will be a brief status update on the work, as well as a discussion on benefits and challenges before I too hand off to Davis to discuss our communication plan. So leading first with where we're at, Plan W, with the W standing for wellness, has been set up in PharmaCare's PharmaNet system. This will be a fully paid plan for our First Nations clients. The plan will be a first payer of prescription drug benefits. There is no income testing, no deductible, and on the technical side, the work has been completed, tested, and everything is in place and ready to go for our October 1 launch. In terms of eligibility and access, if you're eligible for coverage under the current drug plan through the FNHA, then you will be eligible for Plan W as well. BC Services Card, specifically, that's with your personal health number or PHN, and your status card are all that you will need to access drugs under the Plan W PharmaCare plan. For the vast majority of clients, we expect coverage for prescription drugs will not change. That said, for a small percentage of clients, a change in drug therapy may be required. We certainly ask that those clients discuss this transition with their doctor or nurse practitioner and or their pharmacist. And when Cindy Preston comes on the line later in this call, she'll get into some of those specific scenarios. Richard mentioned as well that we're continuing work in the background with a third party to address specific items not covered by PharmaCare. This includes over-the-counter medications, or what we call OTCs. In the short term, we do expect coverage for these items to largely continue with NIHB, but as Richard mentioned, over the longer term, we're working on a request for proposal or RFP to identify a new partner to assist us with that piece of the work for OTCs, as well as other benefit areas for vision, medical supplies and equipment, dental as well. We believe there are a number of benefits to our clients through this transition. First, I would say alignment with provincial practices and standards. We anticipate better ease of use for clients who will no longer be required to navigate between federal and provincial services. Our clients will also have access to a formulary that's consistent with all other British Columbians. Second, in general, BC pharmacists and prescribers are more familiar with PharmaCare than NIHB because it's part of the system that they work in every day. So that means things like special authorizations or what you might call exceptions will be completed more efficiently. This becomes now a physician-driven process, and as I said, it's consistent with the process that doctors and pharmacists are familiar with for all other British Columbians. Third, FNHA clients will also now be eligible to access other PharmaCare plans and additional provincial programs. So what that means, just to provide a few examples, are things like seamless access to treatments such as care therapies and the opportunity to access educational programs for blood glucose monitoring, just to name a few. In general, we expect this transition provides the opportunity to build closer working partnerships between pharmacists, physicians, and nurse practitioners, and we really expect and hope that this will provide the opportunity for our clients to become more empowered in the management of their own healthcare. Finally, I would say we also expect that once this transition is complete, we'll be better positioned to transform the pharmacy benefit program to better reflect the cultures and perspectives of BC First Nations and to incorporate First Nations models of wellness into our work. Now, with those benefits, we do see a number of challenges ahead. First, a move of this scale from NIHB to a provincial plan is really something that has not been tackled before. It's work that's dependent on strong partnerships. We're working very hard, as are our partners, PharmaCare and NIHB, to achieve a successful transition, and really still working to finalize some of the details of the work. And again, Cindy will get into that as she talks through some of the finer detail of this transition. This is also our first attempt to reach out to our entire client base. Davis will speak to this piece in more detail, but briefly, we have a broad communication plan ranging from Facebook and radio ads to direct client letters, really trying to get the word out so that people receive the information they need to understand the changes. There are also 3 points, the final 3 points on the slide, that we want to highlight to help people prepare for the transition. First is out-of-province coverage. BC PharmaCare is a provincial program, and aside from a small set of border pharmacies in Alberta and the Yukon Territory, coverage is not provided outside of BC. This has really been a significant piece of our communications initiative, and we're asking people that if you're traveling, please plan and get the prescriptions, the medication you need before leaving the province. Second, some clients will need to speak to their healthcare providers around the possible need to transition to a comparable drug therapy. We're working with PharmaCare, with Health Canada, and also with other partners to ensure continuity of therapy on certain drugs that are not covered, that are covered under NIHB, and where an alternative accepted therapy is not available through PharmaCare. We've done drug grandparenting for thousands of clients. We've developed targeted provider and prescriber communications, and we're working very closely with the BC Pharmacy Association to help resolve other issues in this area. Again, Cindy Preston, our FNHA pharmacist, will speak to much more detail on this in the FAQ portion of the call. And then a final note, just for me, on over-the-counter products. These are items that are not currently covered by BC PharmaCare. However, we are working closely with NIHB and expect that most over-the-counter drugs, or OTCs, will continue to be covered by Health Canada. As I mentioned, this will remain in place until we are set up with a third-party provider to support us with this area of pharmacy. So with that, I'll thank everyone for your time, and I'll pass the call to Davis to discuss communication.
Great. Good morning again, everyone. So for those that don't know me, my name is Davis McKenzie, and I'm in the communications department here at the First Nations Health Authority. Many of you may have started to see our communication products actually rolling out into your health centers and other venues. But what I'd like to do today is just provide a bit of an overview of our strategy so that you can understand all the tools that are available to you in communicating and reaching your clients at home. So I think just to start with some key messages. Really, we have about sort of 5 top tier key messages to keep in mind, and these are included in your marketing kit. And this is just really, these are the ones we really want to reach clients with. And one is the time frame. So this transition is happening on October 1st, 2017. So keeping in mind the date and time frame for the change. I think secondly, we just always want to reiterate that about 90% of our clients will feel no changes or impact to this. So really, these are folks that will go to the pharmacy counter and really nothing at all changes for them. Those changes of records, forms, that all happens in the background. So really a high majority of our clients will not have any changes to their prescription drug benefits. So I think this is an important message to share at every opportunity. So as alluded to, there are no new forms required. The transition of records and data on this happens in the background, and we've done various privacy assessments to ensure that that's done in a sound way that protects patient client data. I think importantly, and we've been getting this a bit on our Facebook page, just around the no new forms concern, is that this is not an income tested program like many other programs through PharmaCare. So it's just important to note that you don't need to go to the PharmaCare site and fill out those forms. Really, that happens in the background. The fourth point is just in accessing services, we want to remind people that your personal health number, so your care card or BC Services card, and your status card is all that you'll need to access PharmaCare. So no change from today. That's what's required today. And then finally, we just want to encourage and remind people to plan ahead before you travel out of province and to get your medications before you leave. And what we understand is that for most medications, you can get, is it about a 3-month supply, Cindy, or a 100-day supply for some? Yeah, so I think we just, those options are available, and we're really encouraging people to plan ahead. So as Darren had mentioned prior, we haven't reached our 143,000 clients before, so this creates a communication challenge for us. So as many of you have received your client letters now, we have sent out 91,000 client letters, and those are to all adults that are on our eligibility list. So you would have received a letter sort of outlining some of the basic change. Another letter will be coming to clients later in September. So as some of the final details are being worked out, we will be sending a second letter, and we do appreciate your patience with the address list. I would say we've had almost 3,000 returns, but for 91,000, that's not too bad. So we're working on it and really working to reach folks in their homes. I think what's important to know about our channels in reaching clients is that our website is really the go-to place for information. So for accurate and up-to-date information and frequently asked questions, please do visit our website at fnha.ca/benefits. We have a PharmaCare portal with a lot of up-to-date information. We have started to roll out as well our social media campaigns. So what we do know is that a lot of our people are on Facebook, and we do have about 18,000 followers on our Facebook channel. So we're doing a combination of paid and organic Facebook posts to reach clients. And we've had some really great engagement and dialogue, and we're answering questions each and every day through our Facebook channel. So that is a channel that's open. We know people are there, so we're really working to take advantage of that. We've developed a short video that describes the change, I think, in a way that's quite clear and simple. So we've distributed that to health centers and also have that up on our social media. So we would encourage people who want to know sort of the basics about the change to take a look at that video. And I think we've got a couple hundred shares on that one already. So it's quite effective. I think the final note with working with clients is we know that First Nations health centers, the Aboriginal Friendship Centers, the patient liaisons who work in the hospitals, our own community engagement coordinators, there are a number of people, including and especially our regional teams that are working each and every day with communities and clients. And so we've created a bit of a marketing kit, which I'll talk about a little bit later on, that's been mailed out to 450 locations, including our most high volume pharmacies. So Cindy and the team did some analysis of where most of our pharmacy claims are being processed, and we selected the top 50 pharmacies and sent marketing kits out to them in order to reach our clients. So there's a whole stream of activities that we're working directly with pharmacists, doctors, nurse practitioners, other prescribers. So we'll talk about that in a moment. But the marketing kits have gone out, and we encourage you to set them up at your front desk reception. And it really, if you have any questions at all, please refer people to our 1-800 number. We've got that staffed up, and we're taking many calls daily now. Just briefly on working with health providers, I just want to recognize that PharmaCare and the Ministry of Health have been a really good partner for us in this work, and a really good communication partner. So this is their business, and they've been doing it for a long time, and they're very good at it. So we are working closely with them, and they are also communicating directly to pharmacists around this change. So people tend to pay attention when it comes from the person who pays the bills. It's just a reality of life. So having PharmaCare on board to communicate also to pharmacists is very helpful to us. We're also working with Health Canada closely on the transition to ensure that it's a smooth one. The BC Pharmacy Association, there's a whole series of activities, and we're actually headed out to the regions to be doing workshops with high volume pharmacies in 5 of our most high volume areas. So that's some work that Cindy Preston, our pharmacist, is leading. And we're very encouraged by that. And that's work we're doing in partnership with the BC Pharmacy Association. There's some specific webinars taking place for doctors and nurses as well as pharmacists. That work is now underway. So I apologize for the small and blurry graphic, but isn't it beautiful? This is our communication roadmap. It provides you just a little bit of a highlight. By way of navigation, the green boxes are some of our joint communications, and the blue boxes are things that we're doing on our own. So as you can see, we hope it's a sunny day on October 1st. That is our transition day, and it's also the 4-year anniversary of the First Nations Health Authority taking over the major service responsibility. So a good day to mark and to move on to the next chapter of this work. I think notably, we have started our social media campaign in earnest, and this is really where we're looking to share the message in a simple manner out there around what's happening. Particularly those few things that people need to do, planning ahead, etc. September 1st, our communication activities, I think we would say in communications practice, we're amplifying the message. So we're looking to get loud. We did some research around the Medicare, Medicaid enrollment process in the United States. And one thing that we learned is that most people don't pay too much attention until about 3 weeks out for a change. And this is just human nature. We all have our jobs, our lives, and our families. So as we move closer to that date and come up on that three-week mark, we'll really be looking to amplify our message. So we've got a radio campaign, radio ads created, and those will start to roll out closer to that date. In our final days before the transition, there'll be communication from our partners, Health Canada and BC, to the pharmacists and providers, just reconfirming this change is happening. Here we go. So finally, just a brief overview of the marketing kit that many of you may have received in your health centers. It contains posters, brochures, rack cards, a rack card stand, and copies of the client letter. So we do know that it's been a bit of a challenge to reach each and every client. So we have provided a copy of that client letter that can be photocopied and handed out. So we do ask for folks that are clients on a direct basis to please be sharing that letter. It does provide an avenue to reach us with any concerns. So we really want to hear about those concerns. We've also got the video on a USB memory stick. In our consultation with the First Nations Health Directors Association, we heard about the power of the closed circuit televisions that are operating in many of our health centers. So we do encourage you to just plug and play that video and reach a number of clients that way. So I think with that, we'll move into the FAQ portion, and I will turn it over to Cindy Preston.
Great. Thank you, Davis. You mentioned that your social media campaign is underway, and we're starting to see a lot of questions coming up through that. We're also hearing the phones ring in the Health Benefits Operations call center, which is really great. So we're going to go over some frequently asked questions, and the questions that we're hearing really are following into the 4 categories listed here on this slide right now. There's questions about how do I access these provincial drug benefits, whether they be through PharmaCare or the provincial agencies. And so with these drug formulary differences between NHB and PharmaCare, how is that going to impact me? How is that going to impact my family? There's questions around transitional special authorities. We said that we're going to grandparent coverage. What exactly is that? And what do I have to do? And the last one is, a lot of the questions are around, okay, well, this change is happening and I understand why from the messages you're providing, but how do I make sure my community or my family has, you know, everything in place, or what can we do to make sure that this is a smooth transition as possible? Under this category, we've had questions around unique approvals through NHB, such as be the no substitution when someone can't tolerate a generic drug. And we also have had questions about palliative care coverage and compounds. So these are the kind of the categories of questions that have been coming in recently. Next slide. So how do I get coverage from PharmaCare? Well, for most, enrollment in Plan W is going to be automatic, and the coverage will start automatically on October 1st. There are some individuals that will have their MSP premiums paid through their employer or through their employer or through their employer's work plan. If that is the case, you may need to contact FNHA to have us enroll you into the plan. And it's really because the FNHA today is not paying for your MSP premium, so we don't have your MSP care card number, the BC Services number. So the NHP coverage for these individuals is going to continue temporarily until the FNHA client has transitioned and enrolled into Plan W. We are going to be working with NHB over in the coming months to transition all FNHA clients into Plan W. Next slide. So we've talked about this in the last webinar, and we've talked about it already today in this webinar. So what happens when I travel out of province and I need drugs when I'm away from home? So we talked about there are some pharmacies on the BC-Alberta border that have the ability to bill PharmaCare. And these are the most common pharmacies in those service areas. FNHA is working towards a solution so that we can allow the out-of-province payment of claims. Clients may have to pay out of pocket and submit official pharmacy receipts for reimbursement temporarily. We're going to have more information on this as we get closer to the date of transfer. There's a very limited number of pharmacy items that will continue to be available out of province through the NHB program. And so there will be more information about that too. This will, I mean, we are saying, you know, encouraging individuals to plan ahead whenever possible and get your prescriptions filled before you go. But we know there's going to be circumstances where you're unable or if something happened that you couldn't have predicted, and you may find yourself without your drug that you need. So we are looking to have that solution in place for you. Next slide. So there's been questions about what is the role of the BC Cancer Agency, the Centre of Excellence for HIV/AIDS, BC Transplant, and the BC Renal Agency. These agencies provide drugs, and how does this all fit together? Well, prescribers, your doctor and or MPs, can register clients into these provincial agencies to receive the specific program, services, treatments, and this includes the drugs. So the drug coverage in BC is not duplicated in the BC PharmaCare formulary. So this is where if you need to access these drugs for these purposes, you will have to obtain them through these designated agencies. FNHA is supporting clients through this process, the process of registering, as well as accessing the drug through the agency's processes. Each agency is slightly different, and there are different places and processes to access the drug. So we'll go to the scenario. The scenario on this slide will help explain, and I'll kind of break it down a little bit more. So in this example scenario, Dan lives near Parksville on Vancouver Island. Dan has chronic kidney disease, and his doctors register him with the renal agency. Dan has been getting all of his medications from the local pharmacy in town, and he's got a great relationship with that pharmacist. After October 1st, Dan will now receive his medications to treat his kidney disease from Central Drugs in Nanaimo. This pharmacy is contracted by the BC Renal Agency to provide specialized pharmacy services and provide the drugs for renal disease, for kidney disease. He's chosen to continue to visit his local pharmacy for his other medications. So in this change, for his kidney medications, his renal medications, he does have to access a pharmacy that's associated with the BC Renal Agency. This is different. Before, he was able to go, into his local municipality and receive it from the pharmacy there. So Health Benefits realizes that is going to be an impact to patients. There's a process change for Dan, as well as it's going to be a burden now to make that change temporarily. So we are going to be working with clients to support this. And we are looking to see if there does need to be some modifications to our existing medical transportation policies to support this. We know in general that most clients for these agencies have already been registered and are accessing through the appropriate mechanisms. But we know there's a handful of individuals that haven't fit into that system yet. So we want to be able to transition those those individuals over the next period of time into accessing through those agencies. Okay, so we'll go to the next one. So, are there actually differences in these drug formularies and what's going on here? So, yes, there are differences between the NHB and the BC PharmaCare drug list. They do differ. FNHA has been working with NHB and PharmaCare to transition the coverage to ensure clients will have access to the medications they need after October 1st. So this is going to happen through a number of ways. One, BC PharmaCare Plan W. It lists the bulk of the prescription items. PharmaCare also has a limited coverage drugs, and these are drugs that, if you meet criteria, you can access, you'll have full coverage through this special authorization process. For clients on existing therapies today, we're going to put transitional special authorizations in place. This will make sure that coverage is there and there's no disruption in ongoing coverage. So we talked about the BC agencies, where the medications for cancer, for kidney, for transplant, and for renal will be available from. And then for items that are currently available today that are not currently covered in PharmaCare, we will be working with NHB to have a mechanism, and PharmaCare to have a mechanism where these drugs can be addressed. We're going to have more information on that in the coming weeks, and so we can flip to the next slide. So let's talk about grandparenting coverage and the transitional special authorizations. So right now, FNHA and PharmaCare, we're putting over 100,000 different special authorizations in place. We're really making PharmaCare work here. The special authorizations, these are for drugs that are limited coverage, so they will continue on after October 1st, no disruption in coverage. And we're also going to have exceptional special authorizations. These are going to allow coverage for drugs that would otherwise be considered non-benefit in PharmaCare. Special authorities have different expiry dates. Some are indefinite. So that means that your prescriber applies for a special authority one time. And when it's approved, it's there for life. There's no more annual reviews. You don't have to have that renewed when the prescription expires or anything like that. Once it's there, it's there. That's a big change. There's a lot of drugs like that. There are drugs that will require renewal, and these are ones that are usually looked at an annual basis. There's a smaller number here, and it's usually these are drugs that are usually prescribed for conditions that can change. So prescribers we're putting the special authority in place, and the prescriber, so that on October 1st, nothing happens, the coverage continues. But the prescriber will need to reapply, or will need to apply for special authority within 4 to 6 months. And that's just to make sure the ongoing transition to the prescriber and PharmaCare relationship happens. Okay? There is a small number of high-risk drugs, and these are drugs that, like for safety reasons, or for drugs that are intended for short-term treatment. We're going to grandfather a 35-day special authorization there. And if it is needed beyond that period, the prescriber will apply for the special authorization, transition it into their prescribing authority, and then coverage will be able to be reviewed and in place beyond that. So we'll move to the next slide. So a very, very common question, do I need to change my drugs? Okay, and so in this, yes, in some cases, there will be some changes to the drug therapy. These will usually fall into a reassessment of drug therapy, consideration of alternative drug in the same class. It might be a change in strength of the chemical or in a different format, or a change in manufacturer. Now, this is the minority of the items that we're talking about, but there, in some cases, in a small number of cases, there will be a change that's required. I'll go into each of these in the next slide. So for reassessment of therapy, these are the two most dramatic ones that we have. So they impact about 20 clients, each drug. So both of these drugs are for diabetes. First one is acarbose. It's also known as glucobay, is the brand name. And the other one is glucanorm, rapinoglide. Both of these drugs are not going to be available for coverage after October 1st. And we are looking for prescribers to reassess the drug therapy, assess if these drugs are needed. there are a lot of other options, and at times we are finding that the trend for these drugs definitely warrant careful consideration for ongoing prescribing. You'll see with the glucanorm, there is a caveat there that for clients with cystic fibrosis, their coverage is available. Okay, so we'll go to the next slide. So there will be some changes where we're going to ask that other alternatives in the same drug class are considered. So drug class, so what that is, drugs within the same class act the same way and pretty much have the same side effects and the same function, the same action. So you'll see here, there's 4 that I've listed here. And one, like the first one, for example, is used for benign prostate hyperplasia. So we would say, hey, there's other drugs in class that are newer and better. Can we consider coverage for those? There's less than 5 clients that are impacted by this drug. Moxifloxacin eye drops and Nifemic, these are both eye drops that are commonly used after someone has cataract surgery. These are the newest and fanciest and greatest drugs out there. But when you look at the literature, there's not a lot to really give them a real amazing benefit over what already exists. So these drugs are not covered within PharmaCare. Okay? And these are very common drugs and the other drugs as well, they're alternatives. You see the use here is about 995 clients. The alternative, the ciprofloxacin eye drops, the use is way higher. It's just this drug seems high, but there's another alternative that's used even more. Same with the anti-inflammatory one, the Nifemic eye drops. Those 2 have about 360 clients, and quite often, as I said, with cataract surgery, these are very commonly prescribed drugs, and they usually are prescribed together with actually a corticosteroid eye drop as well. The last one listed here, the Januvia. This one affects about 500 clients, and we've talked about this one before. This is one where for Januvia brand, this drug is not covered in PharmaCare. Other drugs in this class are available, and we would be asking prescribers to consider an alternative drug in the same class for these ones. Okay, so now let's take a look at the drugs that require a change in strength or format. So what does this mean? Well, this is where we have the drugs that are available, the chemical is available, but it may not be available in the same strength that exists in NHB. So we'll take a look at Altace. It's a really common medication. It's an ACE inhibitor, quite often used for high blood pressure. So Ramipril 15 milligrams is not an eligible benefit. Ramipril 5 and Ramipril 10 milligrams is available. So in this case, we would have a client would switch from 15 milligrams to 1 tablet or 1 capsule of the 10 milligram and 1 of the 5 milligrams. Similarly, we'll look at the paroxetine just below it. So paroxetine, the 10 milligram yellow tablet, it is not an eligible benefit in PharmaCare, but the Paxil 20 milligrams is, and the Paxil 30 milligrams is. So what we'd expect to see then, or what clients can expect to see, is that rather than getting that yellow pill for an antidepressant, they would receive half of a pink pill, or their pharmacist would tell them, hey, you are now taking half of this, it now equals Paxil 10 milligrams. These are changes that the pharmacist can do within the pharmacy. It wouldn't require a conversation with the physician. Even the last one there where you see the acyclovir cream, this is a cream that's quite often used for cold sores. It's an antiviral cream. The ointment is available, and that's no problem for a pharmacist to adapt that within the prescription without requiring a doctor or NP involved. So the last one here is a change in manufacturer. This has been a big question. You know, we list the drugs that are not available, and if we look what we have in our claims, we go, wow, there's so many drugs that aren't going to be available, but they're actually, the chemicals and the drugs actually are. It's just all the different versions from all the different manufacturers are not. Okay, so this is where BC PharmaCare is different than NHB. They don't list everything on the Canadian market. They pick and choose, and they make some real effort to make sure that there's consideration around price and the ability for meeting the demands of BC residents. As we all know, generic drugs are usually less expensive than the innovative brand that was its predecessor, that first came onto the market. Generic drugs are required to have that same active ingredient, the same quality, and the same performance as that as the brand name drugs. So I want to go into this one step further, just to demonstrate the brand and generics manufacturers involved with metformin. So go to the next slide. Okay, so here's my example of a change in manufacture due to the way the PharmaCare lists their drugs. Let's talk about metformin. Most people are familiar with this drug. It is a diabetic drug used to treat diabetes. Okay. On the Canadian market, there's 47 different brands. These are all made by different manufacturers. 15 of these brands are listed in PharmaCare, where PharmaCare said, yes, we will pay full price for this drug. And in PharmaCare, these would be considered the low-cost alternative. These manufacturers have agreed to provide the drug at this price. It's interesting to note that in this one actually includes Glycon, and Glycon is a brand name of metformin. So one of the brand names of metformin is actually included in the low-cost alternative, and that's not necessarily unique to metformin. We will see that the one brand glucophage, that's another brand name of the metformin, it's covered up to the low-cost alternative. So it is listed. You could choose to get that brand name, but it would only be covered up to the lowest cost alternative price, the price of the generic drugs and then the Glycon brand. Okay, so we're going to talk, this question is really how people are saying, well, how are we going to have this smooth transition? How are we going to do this best? I had a reaction to generic drug, and my doctor said, I needed to try this brand, no substitution for another brand. What are we going to do now? Well, we understand, like, there are definitely, people do react to different manufacturers' products differently. And sometimes there's cases where an individual can't take a brand. FNHA is working with PharmaCare to ensure that clients who have been approved for this no substitution coverage or other unique approvals, such as exceeding quantity limits, like we have sometimes seen with blood glucose test strips, that coverage can continue. So if this does apply to you, if you have had no substitution prescriptions, we want you to contact FNHA. We want to help ensure that there is coverage ongoing. We've tried to find these claims in our data, and we can't find them. It's like looking for a needle in a haystack because they're not flagged within the data. So we are asking, if you or a loved one, if this seems to apply to you, please reach out to our health benefits operation. After October 1st, 2017, prescribers will be able to request no substitution coverage through BC PharmaCare processes. It does exist, much like it does in NHB, where you will, if there is a reason why you cannot tolerate the alternatives that exist on the formulary, you can get that coverage for a no substitution. So another question we've had is, FNHA announced improvements to access for palliative care drug benefits back in January 2017. Is this changing now? Absolutely not. We made that improvement, and we intend to keep moving things and getting things in a better state and easier access. Doctors and NPs should continue to register palliative care clients into the palliative care program, into Plan P and PharmaCare, and also register their clients with a local health authority. This helps to enable coverage for the palliative care drugs and medical supplies and services, which are often tagged within the health authority. Our nursing group is working with palliative care in BC as well to make sure that these services and connections are really working well for our communities. So FNHA is alerting prescribers, the doctors, the NPs, to really make sure they're enrolling their clients into the PharmaCare palliative care program. FNHA is going to be contacting the pharmacy providers to ensure that they're aware that this coverage change is taking place. So that'll be my team connecting with the pharmacy providers where we know that there are NHB or clients identified as palliative in the NHB program. Yeah, we'll move to the next slide. Another question we've had is, I get my medication and it's a cream, so how, my pharmacist kind of looked at me funny when I said I was changing my drug program. What does that mean? So compounds. So these compounds are the medications that are not commercially available. So your pharmacist usually has a prescription from the doctor to mix a few things together to provide you that cream. We know that there's approximately 12,000 clients that were dispensed compounds in 2017. So in the two formularies, the way that the compounds or these mixtures are identified are different. So we can't compare X equals this apple equals this apple. It really is a challenge. We're taking that challenge head on. So what we're doing is wherever we need a special authority that we can determine, we will put that into place so coverage can continue. But we are asking the pharmacists to be aware of this and prescribers, because the BC pharmacy policies and coverages will apply after October 2017. So there, in some cases, there may need to be changes to the compound ingredients, and the pharmacist will have to bill according to the program rules, the PharmaCare program rules. FNHA is working with PharmaCare, as I said before, to have the special authorities in place when we know that the compound will require it. And I think that summarizes really what we've said and kind of the main topic for that, smoothing the transition. All right.
Great. Thank you, Cindy, for the overview and the detailed answer to the questions that we've been receiving to date. So we've got a number of questions showing up in the chat box. So we'd like to, let's give Cindy a break, and maybe we'll turn our first question over to Darren. We have a question on the line. How prepared is PharmaCare for the increase in the number of people accessing their program?
Yeah, thanks, David. That's something that we have been talking with PharmaCare about. We are a very large plan, as Davis mentioned, over 140,000 potential claimants under our new Plan W. Although from the PharmaCare perspective, we're actually a smaller component. They offer coverage, the largest drug plan in British Columbia, coverage to several million people, in fact. And so what for us is a large plan is a smaller scale implementation for them. They've also gone through large changes like this in the past, so they have some experience from implementation of other program changes, such as a reference drug program change that happened in the recent months. So they're able to draw from that in their experience and to be able to scale up to handle influx of calls and changes in processes. So I agree, we have a very large implementation here, but I think PharmaCare is well positioned to handle that change. Cindy, is there anything you'd like to add to that?
Great. Thank you, Darren. So our next question, and this one is for you, Mr. Jock. Is there an opportunity for FNHA to explore owning and controlling a pharmacy program?
Yeah, thank you. Interesting question. And I would say at this point, there's really no impact on that, in that I would assume whatever business is contemplated, it would have to start from a base of billing our plan. So I would think that especially in the beginning stages, there would be no impact on that. And I think going forward, we'd want to work with communities on what that might look like. But I would say there would be no impact on those plans. But I think what we have now with our change to this whole system is we have more flexibility on how we deal with these kind of interests. So in the medium term, I would say we have much more flexibility, whereas the federal plan is quite restrictive.
Thank you very much. So the next question is for me, and this will be awkward, but I'll read it out and answer it. So will a copy of this PowerPoint be made available to us? I'd love to share this info with my team. Yes, a copy of the PowerPoint and the recording of this GoToMeeting will be posted up on the website. So folks can also download and listen to the conversation or view the PowerPoint. So yes, it will be made available. Just give us a couple days following this webinar to get that all lined up and up on the website. So our next question is for Darren, and potentially Richard may want to chip in on this one as well. Why is INAC not included in the health provider list? Is that expected to change? So this really is a question around our partnered list for the change, where we list the BC Pharmacy Association, PharmaCare, the Ministry of Health, Health Canada. The question is, why is INAC not included in that list?
Good question.
I think that's great feedback and something that we can take away and potentially include the distribution of some of our marketing kits.
Yeah, and I think that I think it's very helpful, and particularly the amount of clients that are going into the INAC central offices here downtown. So thank you for that question, and we'll adjust our plan accordingly.
Yeah, for example, some information at the kiosk and the desk where you apply for your status card. So good suggestion.
Great, thank you. So the next question, and I think that this one is for you, Cindy. It's around grandfathering coverage. So if a client's taking a specific medication that they had to get approval for under NIHB, will they be getting indefinite coverage of their current medication, or do clients need to still see their physician?
Okay, so we're working so that on October 1st, we don't need everyone to run into the doctor's office to get a special authority in place. Many of the drugs that clients are on today will receive indefinite special authority. So that means they will not need to see their physicians to have a special authority put into place. There is a small number of drugs that will require a special authority to be put into place. So there's a small number of high-risk drugs for really potentially dangerous medications that need to be monitored quite closely. So those ones will need a renewal after about 35 days. And then there are some that are short-term drugs intended for short-term treatment, which again would require a doctor to apply for special authority after 35 days. So that would be the end of October. And we'll list those drugs out on our website. So just to flag for everyone. There are some drugs that are more like, and I'm thinking more of medications used to treat Alzheimer's. They are renewed every once a year. And so those drugs, for the transition, FNHA and PharmaCare agreed that we don't want everything to stop, all the coverage to stop October 1st. So these drugs, there's a class of drugs, there are, I guess, a number of drugs that special authority will be in place for several months after transfer to give clients time for the next appointment to have that conversation with the physician and for those special authorities to be put into place. We're going to be talking with the pharmacist tomorrow night and helping them understand the transitions for the special authorities and sharing this information with the physicians too, so they can see when the timing is going to be, those expiry dates and those renewals need to be put into place. But for the most part, most drugs, whenever possible, we will provide indefinite coverage through special authority.
Thank you very much, Cindy. So our next question is for Darren, and it's just around seeking more information around the transition. And I believe we have some more upcoming webinars, and just let Darren comment on this one. Darren.
Yeah, thanks, David. And as we talked about, this is work that is really still ongoing with our partners in PharmaCare. So as we move towards October 1st, we are adding additional details to our communication. So we're certainly encouraging people to keep an eye on our website, fnha.ca, where we'll be posting the most up-to-date information as we're able to, working towards October 1. We have another webinar planned for Thursday, September 7th at 10 a.m. I believe that the final slide on this presentation will also include information on that before we close. And we have another webinar scheduled later in September as well. So there should be several more opportunities to engage with us as we work towards October 1st. Always keep an eye on our website, and certainly if you get to client-specific questions, we're certainly encouraging people to call our toll-free line, our health benefits support rep at 1-855-550-5454.
Thank you, and I'd just like to add that we are starting to get a number of client-specific type questions around specific medications, and some of those are being posted on our Facebook channel. And we just want to remind people just around protecting client privacy that we actually can't display those types of comments because it does impact the client privacy. So if you want to private message us, we can get you connected with the health benefits support rep. But our primary commitment is to definitely protecting privacy. So please do call our line with your specific So our next question is for you, Cindy, and it's around drug class. So how will coverage work if a drug class is not covered under PharmaCare? An example provided here is, excuse the pronunciation, Authorizations. What about if a client has tried a generic medication in the past that has caused adverse reactions?
Okay, so the drug in this example here is a new class of drugs to treat diabetes. And right now, PharmaCare does not cover this class. NHB will provide coverage if clients meet certain criteria. So clients who have been approved for this class of drugs, Invokana is another one, will continue coverage after October 1st. We're going to grandfather coverage through an exceptional special authority, so coverage will continue. Right now, these drugs are not listed within PharmaCare as a benefit. In exceptional cases, they may be looked at. We know that when new drugs come onto the market, when the manufacturers can demonstrate that there's value to patient care and patient outcomes, and there's cost effectiveness in that drug treatment compared to other treatments available, those drugs get listed. And in a life cycle of a drug, it doesn't take very long before the drug becomes less expensive after it's on the market for a little bit longer, and more information is available to show its value in treatment. So right now, this class of drugs is under review by PharmaCare. And as with all drugs, even through NHB, we will see them progress and likely end up on the formulary, provided that they continue to have a safe and good value or good impacts on patients' outcomes. So for now, clients who are on existing therapy will continue on after October 1st. A client who is looking for coverage October 2nd likely will not get coverage immediately, and as formulary changes over time, they very well could apply at that time.
Thank you, Cindy. And I wonder just around a bit of a clarification on the point of not coverage at that time. I wonder if you can just sort of, what should clients do, I suppose, if they're in that situation?
Okay, so if a drug is denied, much like there is today through NHB program, there is an exceptional review. So FNHA, outside of PharmaCare, does have an opportunity where we can take a look at requests for coverage. And that's a process that we're building to mirror, at transition anyway, October, it will be very similar to what we already have in place. Again, you will want to definitely be able to have the other alternative treatments tried or reasons why they could not be tried, and then brought to FNHA for a review to see if they're on a case-by-case basis.
Great. So our next question is, what is the FNHA process for handling feedback, I think, related to the transition? So maybe we'll turn this over to Darren, please.
Sure. I guess feedback can come in many forms. We're seeing, as Davis mentioned, some on our Facebook page, and I mentioned our health benefits support rep toll-free line. If you have client-specific feedback, I would really encourage you to reach out to us directly through that toll-free line. This question may also relate to appeals or questions that could come up after the October 1st implementation. That's one of those areas that we're continuing our work and really building out our process in anticipation of that need at October 1st. So as we get closer to launch, we will be providing more information on what our mechanism of appeals will be, recognizing obviously that we will need one at Go Live.
So another question for you, Darren, is will the change mean that clients now have to pay pharmacy fees?
No, as I mentioned in my first slide, this is a fully paid plan, a fully paid first payer plan. So really at the pharmacy desk, the client experience should be much the same as it is today.
Let's stick with you, Darren. We've got another question, and it's Can status cards and personal health be linked to simplify this process? It's being pointed out by one of our callers that this is a bit of a barrier.
Yeah, that's a great question. We've been advertising a request for people to bring both their BC Services card or whatever someone has with their PHN or personal health number on it. For me, that card is actually my driver's license. That's the card, the number that you need to access benefits through PharmaCare Plan W. The reason we've also been messaging the need to carry the status card relates to the coverage for additional items, such as those OTCs that I mentioned would continue to be covered for a period of time through the NIHB program. So really, in order to simplify our messaging, we've asked people to bring both to ensure they have what they need when they arrive at the pharmacy counter. But technically, the question is really correct. All you need to access benefits under Plan W is that BC Services card with your PHN.
Great, thank you. And just again, OTC is shorthand for over-the-counter medication. Darren, one last question for you before we move on to a question for Cindy. How can I receive a client letter if I didn't receive one in the mail?
So two answers to that, I think. We have included a generic copy of the client letter within our marketing kit. So I'm not sure the origin of that question. If the question comes from someone that received the marketing kit, you should have a copy of that sent out with the package. If it's an individual client looking for that client letter, I'd encourage you to call our toll-free line. It may be that we've got an outdated address and unfortunately weren't able to get a letter to you. So if you contact us, we can correct that situation.
Great, thank you. So the next question is for Cindy. Will there be changes to the coverage of insulin?
Okay, so there's, in a pharmacist's brain, there's two questions here. So one, insulin is covered. There are the concentrated insulin. We do have a very small number of individuals on concentrated versions of insulin. They will not be covered. All the other insulins are covered. Now there's processes around the insulin that do differ. There's different benefit status within each program. In PharmaCare, as you progress to different insulins, you do need to try certain ones first before you can progress onto another insulin. So there are some changes there. But again, there are exceptional special authorizations. There's an exceptional special authorization process that if for some reason the regular process cannot be followed to access the coverage, the prescriber can contact PharmaCare and an exceptional coverage can be put into place and jump over those steps. So there are changes to insulin. The drugs, it's very limited, and there are like when we talk about the concentrated versus non-concentrated insulin. I think these questions are difficult to answer in general terms, but definitely there are some differences around the processes to access insulin.
Great, and I think just a reminder for anyone that has concern about a specific client that they're serving, we really do encourage you to call our line so that we can address them on a personal basis as well. The next question is around, I guess, going back to the discussion around agency drugs. And can agency drug pharmacies ship medications to a client? So I guess.
So a lot of things are possible, but this is where we really encourage clients and the family members or client advocates to have conversations with the healthcare providers, with either the agencies or the pharmacies affiliated with those. I can't say yes to every situation, but we do know that there are some, there is shipping and Canada Post for medications can happen. There's nothing to say that won't happen. And in those cases, Health Benefits is looking at what we can do to support patients in those situations. For example, we know that shipping costs are not covered in general. So that's something that we're also looking at.
So it's possible.
It is possible, and I think it really is a case-by-case basis, depending on each unique situation.
Thank you for that. So I'm getting a question. We'll do the awkward thing where I'll read it and answer it again. Can we receive more marketing kits to share with other community members, both on and off reserve? And we have accounted for that in our printing and marketing kits. So we do have a number in storage that are ready to ship. So we would just encourage folks looking for more marketing kits to please email healthbenefits@fnha.ca or call our number that's up on the screen right now, and we'll look to get you some more marketing kits shipped out. The next question, and this is back to you, Cindy. What are PharmaCare's dispensing times for narcotics?
So again, this is one where we really want our clients to talk to the pharmacist, because there's dispensing times, and we do have the 100-day supply, which we see in NHB. In a lot of cases, it's appropriate to only have a 30-day supply of narcotics or benzodiazepines. So for these changes, we would expect them to be around there. Now, that said, there is always opportunity for exceptional coverages, being that we are moving from our federal program with the allowances that we have into the PharmaCare program. So again, those would be considered on a case-by-case basis. But in general, it would be good practice, at a pharmacy to supply a 30-day supply.
We're capturing a number of comments and questions in the chat box, and they're related to the other benefit areas. So we've got a number of questions showing up around dental, vision, and some changes to that program. So maybe I would just provide a general question to you, Darren. Is how does this impact some of the other benefit areas? Are there changes that we need to be planning for?
Yeah. As Richard, I think, mentioned early on in the presentation, at this time, we're not making changes to the other benefit areas, dental, vision, and as examples of that. We are doing work actively on prepping for a request for proposal to find a partnership to help us with the administration of those benefits. So changes will be coming down the road, but those benefits are not changing at the October 1 date.
Great. Thank you. So I think we'll, another question for Cindy. How can clients, with the assistance of their pharmacist, appeal for medications that are not covered under PharmaCare?
Okay, so I think with this, we really have to keep in mind the purpose of an appeal is really that request for exceptional coverage when all the other alternatives that are available haven't or won't work for that individual. So with that, it will be a request coming into our health benefits operations for review. We'll be working with PharmaCare to make sure that this drug has either been reviewed for an exceptional special authorization within PharmaCare, because we know those can happen for many drugs. If that cannot, then we will take a look at it and apply our principles for looking at appeals within our health benefits program. So we would look for the client and their healthcare professionals to provide us the clinical rationale for the coverage.
So I think another question for you, Cindy, and the question is, it's quite specific around just an opportunity to elaborate on some of the information that had been sent out to some of the clients from Three Rivers Pharmacy. And just a note that it's had an impact on our community and that they're the only pharmacy near our community. So I just wonder if you can elaborate on some of that in our discussions with Three Rivers.
Sure. So there is some concern that there's changes within the formularies. 2 different drug programs with 2 different drug lists and different processes that apply within each program. Tomorrow night, we are having a pharmacist-specific conversation. We're having a webinar, and the Pharmacy Association is helping us with that. It's going to be recorded so that pharmacists can watch it and learn from it. It's going to be posted online. So there hasn't been formal communication to pharmacists to date, right? So tomorrow will be the first formal conversation with pharmacists explaining the details of this change, the reasons for this change, and what those changes are. and how they can help our clients really transition smoothly. So, I mean, it's great that we have pharmacists that are so compassionate and really want to help our clients navigate through this. We really need to help our pharmacists understand the reasons behind the change. But I think that with the Pharmacy Association, we are planning several events. We're going to have pharmacists that are going out to pharmacies, talking one-on-one with the pharmacy staff, talking about the changes and what they can do to really smooth the transition for clients. Knowing that there are differences in the formulary, what does that mean? And what does it mean for our clients in the long run? So we know that with PharmaCare serving the BC residents and the 4 to 6 million people who live in BC, that there is good options for drugs out there, and people will receive medicines that they need.
Great, thank you. And I think just around some of the following up on that, we would also encourage anyone with any concerns who's received that flyer to again contact our health benefits support line, and they can talk about the specifics of any of the medications listed there. So we're ready to have those conversations with our clients, and we do want to hear from you.
Yeah, and I just will add too, with the Pharmacy Association and the pharmacists involved with those pharmacist peer conversations, pharmacists helping pharmacists. We are also looking to have, as you mentioned earlier, Davis, a series of meetings with pharmacists and healthcare providers in the areas, and bring in community health leads as well into that conversation. We are looking to go up to Hazleton in the area in the very near future. It'll be one of the first of those series.
Great. So just a question here for Darren. Is the pharmacy's dispensing fee covered under Plan W?
So I'll just answer this briefly and then invite Cindy to jump in. Short answer is yes, the dispensing fee is covered under Plan W. As I mentioned, we have a fully paid first payer plan with PharmaCare.
Yeah, so a fully paid plan in PharmaCare, what that means is that the drugs that are eligible for coverage are fully covered. There is no additional markup, and there's no additional fees tacked onto those for patients to pay out of pocket.
And just another question here for you, Cindy. Will this transition mean pharmacists will better understand who covers drug costs for First Nations in BC?
Yeah, I mean, this is a hard question for pharmacists to answer. We went to school to learn about drug therapy and how the drugs work in the body and how to get the best outcome of your drug and make sure that that drug therapy meets the needs and the goals of care of each individual patient. So when it gets into navigating drug program coverages, it's a learned skill the more you practice. So for BC PharmaCare, that is the BC program for BC, and the healthcare professionals and the prescribing habits and dispensing habits fall within those program rules. So often, largely in BC, the change to PharmaCare will benefit pharmacists. They will only have to navigate one program. We do know that we do have, in certain areas, the First Nation population is greater than the general BC population. And in those areas, the pharmacists know the NHB program inside and out, backwards and forwards, and they have been able to navigate a seemingly difficult program quite easily. But now, in some cases, pharmacists are going to have to relearn some of those processes.
Thank you. So the next question is a communication question. Will this Q&A also be posted with the presentation? Yes, the Q&A will be posted with the presentation. So thanks for that question and confirmation. Just a quick question for Darren, and probably Cindy will have a bit to add, and a bit of this ground's been covered. How is the First Nations Health Authority communicating this transition to healthcare providers? So we've talked a little bit in the opening about the partnership with the BC Pharmacy Association, and there are a number of activities underway. So maybe Darren, we'll start with you.
Thanks, Davis. And this is a difficult one to answer only because I know I'm going to forget someone. We've gone out and talked with a number of colleges and professional associations, and I really need to say that each one of them has been very very receptive and extremely helpful. We've talked a lot about the BC Pharmacy Association as really a key stakeholder in this work, but we've had great conversations with groups like the BC College of Physicians and Surgeons, the College of Registered Nurses of BC, the Association of Registered Nurses, amongst others. And really what we've been doing is working with them to try and obtain support in using their channels in order to help get our messaging out to the various healthcare providers in BC. And as I said, everyone's been very receptive. So we've been getting a lot of help from other partners in helping to get our message out to healthcare providers across BC.
So the next question is for you, Cindy. Will clients who currently have a private health plan on file with their pharmacy be automatically switched to PharmaCare on October 1st?
Okay. So today, NHB is the payer of last resort. So that means if you have an extended health plan through your work, it is expected that your pharmacy will bill your extended health plan and then NHB. Okay. October 1st, tomorrow, in PharmaCare, PharmaCare is the first payer plan. So that means that if a drug is eligible within that plan, there's going to be no question of who pays for it. FNHA is going to pay for it. Anything outside of that will then be eligible can go to your private health plan. It's really important. This is a big switch, and for those who do have extended health plans, especially ones that do have lifetime maximums, we don't want to be maxing out on all of your extra potential benefits by using that as a primary source. So we are happy that PharmaCare is a primary or first payer versus the last payer.
Great, thank you. Another question has come up around the marketing kits. And so the question is around who has been sent the marketing kits. And so to date, we've sent them to our First Nations health centers located all across BC, to the Aboriginal Friendship Centers across the province. We've also sent marketing kits to our partners, the BCAFN, the Union of BC Indian Chiefs, and the First Nations Summit reception area. The patient liaisons who work in the hospital, sometimes called nurse navigators or Aboriginal patient navigators, have received kits. Nursing services staff and all of our corporate offices across the province, as well as our regional health authorities and other partners, and our community engagement coordinators and regional teams. So if you haven't received your kit yet, we do encourage you to get in touch. We do have a limited supply, so first come, first serve. We'd love to hear from you as soon as possible. So the next question is for Darren, and it's around our staff support line. So does the First Nations Health Authority have enough staff to support the line? We know our line's going to be hopping busy, so this question is over to you, Darren.
Thanks, David. Yeah, we know the line will be busy, and you know, I hope people understand that we want it to be busy because we're asking clients to reach out to us if they have any questions or concerns. We do expect a substantial increase in our call volumes, both leading up to October 1st as well as beyond. We're seeing a small increase, I would say, so far in what we're experiencing versus a normal call volume. The answer to that question is really not just enough people, but have we addressed the technical side as well? So we are already put in place additional people, human resources, in order to help us towards October 1st, and we will be continuing to ramp that up towards our October 1 go live. We're also putting in technical changes to our conference line in order to be able to handle additional call volumes. What we expect is to ramp the service up towards October 1st and then to continue it in place beyond October 1 for several months to ensure that we're able to meet a continued call volume. And we'll assess that as we go on to determine whether or not we need to keep those resources in place for longer or whether we can begin to slow them down a bit.
Thank you so much, Darren. We now have a question for Cindy, and this is around emergency rooms. What happens if a client is charged for medication dispensed at the ER? Who should they send the bill to?
Okay, so we definitely want to see these bills, and we want them to be sent to our health benefits, the operations. So we need to take a look at these because we have work to do with the Ministry of Health and with PharmaCare to address billings for prescriptions outside of the outpatient pharmacy network of pharmacies.
Great, thank you. So our next question is just logistics. When will the presentation be available online? So it'll take us 3 to 4 business days to process the files and get this ready and prepped and online. So if you don't see it up on Friday afternoon, you will see it up on Monday morning. We do appreciate the question. Darren, will the PharmaCare presentation be shared with political and health leads at the sub-regional caucus meetings coming up? And I think maybe I can take a first crack at this. So the recorded presentation will be available. I also really wanted to point out we've got some more webinar opportunities coming up. So September 7th, we'll be doing another gathering just like this. And I think it's worth noting that the information is changing and evolving every time we present. As we receive questions from clients, political leaders, and health directors, we are trying to refine and provide the most up-to-date information. I would also mention that in September, I believe it's the 21st, and then October 19th, we're going to be doing 2 UBC learning circles around the PharmaCare transition. So this is a great opportunity to tune in from boardrooms across the province and participate in a live video Q&A on the topic. So those are 3 of our upcoming opportunities. Of course, these recordings are available also public and live on the website for sharing as well. Just wanting to note that we've got about 2 minutes left, so we'll take a quick scan in the chat box and maybe try to take 1 or 2 final questions. I'm seeing one again around deductible. Maybe I'll pass this over to you, Darren. Is there a deductible through PharmaCare?
No, this is different from some other PharmaCare plans that you may be familiar with. There is no deductible. There is no income testing. Plan W is a fully paid first payer plan under the PharmaCare umbrella.
Great. And I think with that, we'll just maybe move into some closing remarks. Before we sign off, I just want to thank everybody for their questions. A really, really great session today, and please do share the invite. We'll get it up on the screen now, and encourage your colleagues and friends and family to take part in our next webinar plan for the 7th. Information is available on our website. So thank you again for your participation and questions, and turn it over for closing comments.
This is Darren as well. I'd just like to thank everyone for time and great questions, and really encourage you to keep track of our website, participate in the upcoming webinars. As you can tell, if this is your 2nd or 3rd webinar, that the message is evolving, and so we really would like you to keep engaged with us, and we hopefully we can answer all your questions as we get towards October 1.
And as I mentioned in my opening remarks, this really sets the table for us to do transformation in some of the other benefit areas as well. And I think I really do see that there's been a lot of work to do the detailed analysis and to be ready to address the many questions that are coming forward. So I think you can really see the progress, reach out to the many players involved with this, and appreciate people's involvement, engagement, and interest in this. That it's vital to making this work. So with that, I want to thank everybody for their interest today.
Great. So I think with that, we'll offer a bit of a closing prayer. And joining us in the boardroom, we've got one of our team members, Jordy Johnson. So Jordy, I'd ask if you could just provide the closing prayer.
Thank you, David. All right. Christian Salsakte. Thank you, creator, all here today, for bringing all these great questions, all these concerns for all of our people within the community. Please look out for the people within the interior, those that are dealing with the wildfires, as well as all of our elders. Thank you.
So look for the recording and thank you for joining us again.